recently modified.
Yeah, the slides are up.
Cool. Okay, so yeah, thank you, Selena, for the introduction, and it's really nice to be able to speak to some people up in the Walton Centre as well, and different pain management service to ours, and hopefully at some point in the future I'll be able to come up and kind of meet some of you in person as well. That'd be really nice over the next few years while we work together on the study. So as Selena said, I'm a physio down in Stanmore at the Royal National Orthopaedic Hospital in the pain management service there, and just started my doctoral fellowship funded by NIHR back in January. So it's still really just getting things off the ground at the moment, which is why this is a perfect time to come and speak to your team, really. As you know, as Selena said, I've been having chats with Selena and with Katie about the Walton Centre being involved as a collaborating and participating site in the study. So hopefully it's an opportunity to kind of tell you more about the work that will be going on. So yeah, my PhD is registered. I'm at St George's University, that down in South London, and up in Stanmore for my clinical work at the RNOH. So I'm going to start off with just kind of telling you about the background of the study and some of the earlier work that we've done, and then talk more about the specifics of what the project is and how that might look in practice. And then it'd be really great to have some questions and discussion at the end about how it might work in your service, and any other questions you have about the study or the previous work. So when we talk about physical activity, I really am keeping it very broad, and that's primarily because we know that lots of people in pain will do lots of different activities at different intensities and different times, and really it's important about what's a preference for them and what they want to do. So really using the World Health Organization's definition, referring to it as being during leisure time, for transport, or as part of a person's work, and this also includes exercise. And what we know is that both moderate and vigorous intensity physical activity can improve and maintain health. So, and we know that physical activity has many benefits for people that have pain. So it can help with improvement and management of symptoms, and improvement and maintenance of physical and psychological function and quality of life, and social participation benefits on general health, and prevention and management of comorbidities. So we know that there are going to be some people with pain that don't necessarily agree on the importance or the benefits of exercise, but generally over different conditions and different times, they do generally consider it to be important and beneficial for them. But we know it can be very difficult for people with pain, and they typically have lower levels than people in the general population. Physical activity levels tend to also lessen with people that have more sites of pain and higher levels of disability. And we know that it can be very difficult, and with consistency and the long-term maintenance, which is where my work comes in. And we know this is particular following pain management programs. And I'm going to talk to you in a little bit about another study that we've done recently. And in our own service at the RNOH, we see many people being re-referred for our outpatient service in pain management because people are having difficulty maintaining self-management strategies or have setbacks. And one particular issue they have is with maintaining a beneficial level of or type of physical activity for them. So some of the earlier work we've done during my NIHR pre-doctoral clinical academic fellowship, I did a systematic review and meta-analysis looking at the effectiveness of physical activity interventions and sedentary behavior interventions for people with persistent MSK pain. And essentially what we found is that physical activity interventions have an effect, albeit small and with low quality evidence, but they do have an effect immediately post-intervention, but they don't have any longer term effect than that. So essentially when the intervention stops, the physical activity levels decrease again, so people are not maintaining that change. So we're seeing an issue with people being able to maintain physical activity longer term, particularly when interventions are finished. And during this study, we also did a number of other things looking at methods of delivery and settings of physical activity and types of physical activity as well. But we could only look at those things for the immediate post-intervention effect because of a smaller number of studies. But we also looked at and identified some behavior change techniques that might be helpful for people to change physical activity behavior as well, which can be useful looking forward to intervention design. And these could be adding objects to somebody's environments, that could be helping them to prompt physical activity, setting action plans, goal setting, getting feedback on outcomes, and just having others monitoring, knowing that other people are monitoring their physical activity as well. So our second systematic review that we published at the end of last year, we looked at the barriers and facilitators to physical activity for people with persistent MSK pain, and we synthesized these barriers and facilitators using the theoretical domains framework, which is a behavior change framework which can be used for categorizing barriers and facilitators. And there's 14 domains within that framework. And it just helps to categorize things when you have a huge number, potentially huge number of different barriers and facilitators. So the most prominent ones for top 5 for barriers were people's beliefs in their capabilities to do physical activity, their beliefs in the consequences of doing physical activity, environmental reasons and context and resources, social influences and emotion. And facilitators was also beliefs about consequences, the reinforcement. So experiencing positive benefits, positive outcomes of physical activity will reinforce people's desire to do it further. And again, environmental context and resources and social influences, but also for behavioral regulation. So there's a lot of crossover between what's a barrier and what's a facilitator for people, depending on their individual context. We also compared the barriers and facilitators and TDF and theoretical domains framework domains across the different barriers and facilitators and across different conditions and physical activity types, and found they are mostly consistent. So there's no difference between the different conditions that were included in the studies. But one thing we really set out to do is to try and look at the differences in barriers and facilitators between people that are sort of initiating or the uptake of physical activity versus maintenance. And we weren't able to do that because the studies are not explicitly reporting on those different phases between uptake and maintenance of physical activity. And we think this is particularly important because we imagine the things that would influence somebody from starting their physical activity are potentially different to them maintaining it. We also expect there'll be some crossover between those barriers and facilitators, but we don't know what these are. And this is really important for designing effective interventions. And a recent study that we're hoping will be published soon. We're about to submit the revisions for this, having undergone peer review. And we did a qualitative study where we interviewed people that had finished, that were at least 6 months from finishing our pain management program at RNOH. And we really wanted to understand, well, their perceptions on the program, but also the unwanted effects of programs. This is not something that has been looked at before. And essentially the participants said that PMPs have a really important role in educating and supporting patients to self-manage pain. And many people would reported improvements in their physical function, their quality of life, and reductions in pain medication use. There's also a big feature that came out that maintenance of self-management strategies can be very challenging. And this was across the board. I think even those people that were very positive about how they did still reported some difficulties with consistency over time of self-management. And that can be largely due to some unwanted effects directly associated with a program. So ours is a residential program, so people being away from families can be difficult for people, but also a general sense of abandonment. So when they do a program and we let them go and discharge them, they felt they would really benefit from more support. And then also that if a big theme that came out was about how burdensome self-management can be. So during a program, we will be promoting and facilitating lots of behavior change and changes to people's lives, which can be quite burdensome in terms of integrating those things within their existing life, but also putting a lot of emotional burden on families. So there's some other things to bear in mind when we're thinking about how challenging it can be to maintain self-management strategies, including physical activity long term. So there's increasing kind of work going on around particularly looking at the long-term maintenance of physical activity within different fields. And there's been several different attempts to try and define what we actually mean by physical activity maintenance. And there currently isn't consensus on this or how to operationalize that. There are some suggestions that perhaps different types of thresholds might be a way to do it. So one example of this might be looking at how consistent people are, say, adhering to the World Health Organization's physical activity guidelines. Another approach, which is the one that we're going to go with looking at how much somebody consistently achieves an individual goal they set around physical activity. And we're going to use this definition because we feel that's more relevant for the types of variations in levels that we see in people with MSK pain. And quite an academic definition of looking at shifts in the mechanism of action. So what's enacting on physical activity? So that goes back to the potentially the different barriers and facilitators and how they change between uptake and maintenance. But that's an incredibly, almost impossible thing, I'd say, to really measure in clinical practice. And also people are starting to look at the complexity of physical activity maintenance. So we can say people either maintain activity or they don't, but also there's likely to be some differences within that, of which people are referring to as patterns or types of physical activity. So within that spectrum of people maintaining it consistently or not doing it, there are potentially different levels of people that maybe achieve a low amount, or they intermittently do it, or they fluctuate. And some of the language used in studies now is similar to what's been used in smoking and substance misuse, in terms of kind of relapsing and lapsing, and then recovering from lapses and relapses. And it's something I'm very interested in being able to do, is to really understand this complexity a bit more of this behavior during my PhD as well. But despite all the problems that we're highlighting around people maintaining it, interventions designed particularly at maintenance of physical activity, so interventions that are added on after an initial intervention, have been shown to show promise in helping people to sustain change. But none of these have been developed for people with MSK conditions yet. So really, we don't really know much at all about what might influence maintenance physical activity, about how people experience that, and how we can help people with it and help them to maintain it. So that's where my PhD study comes in. And as Selena said, I'm looking to develop an intervention to help people to maintain physical activity after attending a pain management program. That's exactly what we're aiming to do with my PhD study. So an overview of the study: it has three main work packages that will be delivered over the next sort of 2.5 years. The first study is a qualitative study looking at the barriers and facilitators to physical activity maintenance, so we can understand what the intervention needs to target. And we'll also, in those interviews, ask people about some potential characteristics of an intervention, so how that may look, how that may change behavior, and how we might deliver that. That will lead on to a longitudinal study where we will test the key barriers and facilitators from the first study quantitatively and look at their longitudinal association with physical activity maintenance, and also use a questionnaire and a follow-up survey to get some more potential intervention characteristics from those participants. And then we will take those results from those two studies and co-design an intervention in a series of stakeholder workshops with patients and healthcare professional group. And needless to say, with research now, that patient and public involvement has been really, really important to developing this study protocol, and will be throughout. I'm already learning lots from them and from the various things just in the setup phase of the study. And we'll be recruiting from about 4 different NHS pain management services And the study will be guided by the behavior change wheel. And for those of you who don't know what that is or haven't seen it before, it's a really nice systematic way of developing behavior change interventions. And it was developed primarily at UCL and their Center for Behavior Change. And just to give you a brief overview of how this works. So in the middle of the behavior change wheel is what's called the COM-B model, which you can see on the right-hand side of the slide, which says that for somebody to enact a behavior or maintain a behavior, they need to have the capability, the opportunity, and the motivation to perform that behavior. So through understanding the different things that influence physical activity maintenance, we can understand which is more important or more prominent out of capability, opportunity, and motivation. And we're doing that through those first two phases of the study. And this could sometimes also called a behavioral diagnosis. So once we've understood what influences behavior, we can understand what type of intervention we need to affect that behavior. And that's what the red parts of the behavior change wheel are, is looking at different forms of intervention. So just in there, we've got education might be a type, or incentivization, or training, or modeling, or just some other examples there, but you can see those in the red. After selecting what the intervention will look like, you can start to select, well, what policy type, how are we going to influence policy? Now, this isn't necessarily important for all interventions, but in interventions where we're trying to influence practice, policy is likely to be important. And then after that, we can start to select the different behavior change techniques. So those are the strategies we'll use to influence someone's behavior, and then how we will deliver those different behavior change techniques. That's briefly the process of using the behavior change wheel. So it's very systematic. It can be iterative, but it really lends itself well to designing interventions and developing theory around that. So just a bit more detail about each of the different work packages. So as I said, this first work package will be a qualitative interview study that aims to explore experiences, barriers, and facilitators to maintaining physical activity and elicit some potential intervention characteristics. We'll be interviewing people with persistent MSK pain that have completed a pain management program at least 6 months ago. So in the protocol, we said 6 to 18 months to keep that controlled. And we're looking to interview at least 24 patients with different levels of maintaining physical activity and other important characteristics like age and gender and conditions as well. We'll also be looking to interview some what we call physical activity partners, and there are people that support the patients with their physical activity or somebody they do physical activity with. So when we recruit the patients, they will be asked if they have somebody that they would consider to be a physical activity partner, and if they would like to be interviewed with them. So if the physical activity partners then volunteer, they'll be interviewed together in a dyadic interview. And I'm also really looking to interview different healthcare professionals that work on pain management programs across the different sites that we'll be recruiting from. So anyone who's working on a PMP with patients is eligible to volunteer for this study, and we are looking to get representation across different professions and different sites. So yeah, there'll be semi-structured individual or dyadic interviews, and we'll be using sort of thematic and framework analysis using elements of the behavior change wheel to analyze that data. So moving on to the second study, this is a prospective longitudinal study. As I said, we're looking to identify which of those important barriers and facilitators from the first study will look at their association with physical activity maintenance and also elicit some more potential intervention characteristics. So this will be with people that have just completed a pain management program, so just patients. And we're looking to recruit 100 to 120 across the 4 sites in about a 6-month period, if all goes well in terms of timeframes. So physical activity data will be using a research grade accelerometer like the one in the picture, and they'll be measured at 4 weeks when they've completed a PMP and 6 months later And they'll be setting a goal after that first 4-week period, which they aim to achieve in terms of physical activity over the next 6 months. And then we will be assessing them at 6 months later to see whether they have achieved that goal or not. And that will be then classed as whether they have maintained physical activity or not. And there'll be a series of questionnaires which relate to those variables identified in the first study, which will be associated with physical activity maintenance. So they could just be things like social support and self-efficacy and other measures that we identify in that first study. And yeah, we'll be measuring those at baseline and at 6 months as well. So baseline being straight as they finish a PMP or as close to as possible. And then, as I said, open questions relating to potential intervention characteristics as well. And the various forms of statistical analysis for the quantitative study, the quantitative element and framework analysis in the same way as the first study for the qualitative data. And then for the final study, this is broken down into 3 different phases, where the first phase will be very much around logic model or theory development, but a preliminary theory based on all the evidence from the first 2 studies. And then there'll be a series of co-design workshops after that, where we will be developing the intervention and prototype and then refining it. So in some more detail about that will be a stakeholder group with patients, their physical activity partners and health professionals, same as the first study. And we'll do that initially with 3 half-day workshops, working through different stages of the behavior change wheel. So that'll be designing the initial intervention. There'll then be a phase of developing a prototype, so a version that is a bit of a mock-up version of what that intervention will look like. And that'll be between the research team and patient and public involvement members. After that, we'll do 1 more workshop where we gather feedback on that initial intervention prototype, again from people from the same stakeholder group will be some of the original people and some new people that we'll recruit into that. And then we'll finally refine that prototype again after that. So then we'll finish the PhD with a refined prototype, which can be ready for development and testing in future work. So just on a note of a few different recruitment approaches, because this will be different depending on which site on the resources and kind of processes that different sites have. And I have discussed this at quite good length with Selena and Katie so far, but just to let you know of some other ways that we might be doing this. So for the first study, if patients are attending follow-up appointments in person, at least 6 months after finishing a program, they can then be given the invitation letters and information sheets at this point. If follow-up appointments are online or remote or on the phone, then people can be sent the invitation letters and information sheets along with those appointment letters. I think the method that most places will be using, including the Walton Centre will be doing at RNOH as well, is identifying potentially eligible patients from PMP databases and sending them invitation emails and participant information sheets advertising the study. And for healthcare professionals, they'll be invited from either the collaborator or person I've been working with most in each service to invite them to participate in the study. So all participants will be screened and consented by me. So at this point, it's just about people volunteering directly to me to participate, where I'll screen and consent them. For the second study, it'll be about people will be recruited immediately at the end of their pain management program and given the patient information sheet, so they can volunteer by contacting me directly if they're interested in taking part. Clinicians at each site can either gain consent from me to then contact the patient, so that's a short form patients will need to complete, and then I would give them a call the week after they finish their program to discuss the study further. Or if sites want to be more involved in the consenting process, they can obtain consent from the patients for this study, and then let me know who they are, and I'll move forward with data collection from there. There are other ways that I haven't put on this, we have discussed, which is things around advertising the study in pain management departments with flyers and posters, and that is something that we'll be developing as well that sites can use to help them. And then for the next study, for the first elements of the co-design workshops, this will be very similar recruitment methods to the first study, where we're looking to get people that are at least 6 months from finishing their programs. So that could be, again, from databases, sending out invitation emails to people, inviting them at follow-up appointments, or sending them letters sending the information with appointment letters if the follow-up appointments are remote. And again, for healthcare professionals, they'll be invited by somebody within their service when ready to be recruited for that. And again, all screened and consented, so consented by me. And for the refinement phase, the participants that were in the first phase of co-design will be invited by an email from me if they wish to participate in the final workshop. And then any new participants that we want to invite will be from the same methods as the previous phase. And again, all screened and consented by me. Just to give you an overview of the study again, there's 3 main phases, with the final phase broken into three different phases. We're using qualitative interviews as the first study, and then a longitudinal study, and then the intervention co-design in the final phase. So the impact I hope this will have, I hope in the short term, at the end of the PhD, we'll have a prototype of an intervention, the first of its kind for this population. We'll be addressing an essential need for a highly complex and costly population, and developing some transferable knowledge to the growing evidence base around physical activity maintenance. And in the longer term, will hopefully lead to, if the intervention is developed and tested, hopefully to improve and maintain self-management for people and better outcomes for pain management services. Hopefully that will lead to cost savings for the NHS, and hopefully a wider societal and economic impact if we can help people to return to work, stay in work, and participate more in economic activity. And always a nod to my supervision team. It's very sort of interdisciplinary, multidisciplinary in its approach, of people from St. George's and UCL, and then to Mohammed, who is my statistician as well, who will work with me on the second and third study. And yeah, a big thank you. My contact details on the slide, and yeah, I'd welcome any questions that you have.
Thank you very much, Greg. A lot to cover. So has anybody got any questions? Nathan.
Yeah, hi, can you hear me all right? Yeah. Yeah, thanks, Greg. I think that was really fascinating talk, and I'm one of the pain specialist physios at the Walton Centre. I think you're absolutely nailing where the efforts and energy